just let other people come in as they can. I think I know mostly everybody, maybe one or two people. For those who don't know me, my name is Sheena Bull. I'm a professor in the Community and Behavioral Health Department at the Colorado School of Public Health, and I direct the mHealth Impact Lab. And I'm delighted that our two colleagues from New Zealand could come and be here. And I'll just give you a brief introduction. Judith McCool is an associate professor at the University of Auckland. Her research includes global health, tobacco control, mass media, and social determinants of health. And she's a co-investigator on a number of different research projects that many of which we'll hear about today. Progressing tobacco control in UA, is that how you say that? University of Auckland. UA.
Oh, NUA, yes, sorry, yes. Sorry.
Appraisals of graphic health warnings on cigarette packs, strategies to reduce smoking uptake and secondary smoke exposure of New Zealand children. Keeping Kids Smoke Free, a community intervention to reduce smoking among young people, as well as the New Zealand Youth Tobacco Monitor, a national cross-sectional study of youth smoking. And then Dr. Robin Whittaker, who's an honorary associate professor at the University of Auckland. Robin currently works at the National Institute for Health Innovation at the University of Auckland and does research in public health and medical technology. For a project she's working on currently is effective a mobile phone intervention, Crush the Crave, on quitting smoking in a young adult population of smokers. And she's done a lot of work and is well known for her work in mobile health interventions, including messaging for smoking cessation, work on depressive prevention, alcohol use, cardiac rehabilitation, health information for young families, and diabetes self-management support. She's also the clinical director of innovation in Waitemata's Institute for Innovation and Improvement. Did I get that right? Mm-hmm. So welcome to both of them, and thank you for being here.
All right, thanks very much, Sheena, and thank you for organising. I think it was also Brian organising this event. I have a slight throat issue, so if I start being super croaky, Robin will jump up and help out. So Sheena and I, and actually Robin met Sheena at the same time in events probably over a year ago now in LA, and so some of this material Sheena might be a little bit familiar with you. To you, but what we wanted to do when I approached you about talking about the work we're doing, we just really wanted to share some of the stories and some of the research that we're doing in New Zealand and seeing, I guess, where the connections fall between the work that you're, what we're up to and what you're doing here in Colorado. We also want to learn some things. We want to learn some new skills and new approaches. So that's kind of the purpose of this trip that we have made to the US. So we've been to Chicago, the CUTH conference, the Global Health conference in Chicago, and we talked and we presented a workshop there on measuring the impact of mobile interventions on health, particularly in low visual settings. We're really focused on how do we know what we're doing works, and importantly, how do we know what we're doing works for those who probably need it most. So really focusing on the equity outcomes for mobile health. Then we've been to USC. And spend a bit of time there talking particularly around the area of social network analysis. How can we look at how to communicate effectively, push messages out to hopefully shift or nudge behaviour change or shift social change by using existing social networks. We might pick that up a bit later if anyone's interested in that area. It's sort of a newish field that we're starting to work on. But what we want to talk today was just about some of our work where we're focused on adapting existing, developing new mobile interventions for health, but also adapting those existing tools for other settings. And that's the work that I'm going to focus on. But before I get underway, I'd also just like to acknowledge we are here in the US and it's been an extraordinary time. But unfortunately, as you know, in New Zealand, things are not so good. So I just want to acknowledge our colleagues. The broader New Zealand population is really struggling right now. So I did warn you, so this is really awkward. I'm assuming everyone here is familiar with the rationale for using mobile technologies for health. It just makes really good sense. from somebody who doesn't even know about the technology and how it actually works, disseminating messages, SMS, messages on massive populations to affect some kind of behaviour change. Without even the technical knowledge, it just makes sense. Everyone, relatively everyone, we assume, and to the best of our knowledge, has a phone. And we know that actually messaging, when we've done it in other contexts, not using technology, has been really helpful. Not the only thing that can shift behaviour change, but it's certainly really helpful. So the idea of using mobile technologies, particularly in low resource settings, has made really good sense. And for that reason, the number of interventions and initiatives and pilots predominantly that have sprung up in low resource settings, low middle income countries, has been recognised and certainly represented in the literature. What we're not getting so much of, though, and we're looking forward to hearing more about, is whether these make a difference. Are they really doing what they set out to do? And are they having the impact on those population groups that are not just living in a low resource setting, but even more marginalised by being minority groups within low resource settings? So we're looking forward to that kind of work coming out, and we're hoping to contribute in that area ourselves. So one of the things we've been really quite conscious of doing in the work that we've been focused on in New Zealand and in the Pacific is trying to be really explicit about when we make mistakes, when we've learned some things that perhaps we wouldn't do again and might adapt next time. So what we're going to do this afternoon is really talk about how we've initiated in the development of some new mHealth approaches to really tricky problems, namely problems around managing or preventing chronic diseases, and how we've learnt to perhaps adapt what we do better to make sure that we don't repeat the same mistakes. So we're going to be as frank as we can on the lessons we've learned from doing this work. So again, this is an explicit, we know that this is really important, and I'll talk a little bit more about how ICT development is unfolding in the Pacific Island region. We know globally that that's the trajectory. There's no surprises there. But what we're going to do in a moment now, I'm going to pass over to Robin, who has been really, I think, one of the key people, certainly in New Zealand and some of us internationally, in terms of developing mobile technology.
Thank you. Hi, everybody. So as Sheena said in the introduction, we started off in this area in smoking cessation. So we were the first, my previous boss, Professor Anthony Rogers, was the first to develop a health intervention to be delivered to people solely by text messaging, and the first to do a randomised control trial on this, and it was published in 2005 in tobacco control. And it showed that basically just a purely text messaging program could increase quitting rates by doubled quitting rates in a national randomised control trial. So we went on from there to implement it as a national program. It was run by our quit group, a quit line, and they found it to be as effective as the quit line, but obviously much cheaper to run than a 24-hour hotline. And from there, we also ran a really large trial of it in the United Kingdom, where we ran the text messaging engine out of our office on the other side of the world in Auckland for a big RCT in England of 6,000 people, nearly 6,000 people. And it confirmed that doubling of quit rates. So since then, we've been working with a lot of people on how to implement these kind of programs around the world. And one of the things that I've been doing is working with these people, Be Healthy, Be Mobile, which is a WHO and International Telecommunications Union program to help ministries of health and governments to implement national or really large scale M cessation programs. So we've written a kind of a how-to book. There is a handbook, a toolkit, a kind of book that is available through the Be Healthy, Be Mobile people, which is for ministries of health. If you're thinking about implementing a national M cessation program, here are the steps you have to go through. And just recently, we did a bit of a review of the countries that have done it. These are just some of them, but we looked at what had worked and what hadn't worked in these countries and rolled that into the next version of the toolkit. Costa Rica, the Philippines, Tunisia have all tried to launch international, national size M cessation programs. The one that's missing from there actually is India. So India was a really interesting example where it was very much government led. They implemented a really simple registration process where you can do a missed call. So you just call it twice and then hang up, and you don't get charged for the call, but the people at the other end register your mobile phone number. And so you get registered on the program like that. and within a couple of days they had 100,000 people, and in the first year they had 2 million people. So really, really large scale. And we've done an evaluation of that, which has been published, actually, if you're interested in BMJ Innovations. So some of those really early lessons from all of these large scale projects, just at a really high level. The importance of promotion. So often countries put these programs in and then they kind of forget to tell people that they're there. So there really needs to be a budget around promotion, around mass media, to let people know that they have a program like this. We learned from India that ease of use, particularly registration, is really important. Unfortunately, they made it so easy that a whole lot of people signed up, and when we rang them up in the evaluation, they had no idea what they'd signed up for. And they were non-smokers, never had been smokers. So there's a balance there. You've got to find specific to each context of what will work. But in general, we find it has to be really easy and generally has to be free. So people are not, in most contexts that I've seen, are not going to pay to sign up for a quit smoking program. That may be different in America, but certainly in the context that we've worked in, that's the way it is. Getting the technology right obviously is critical. A lot of those countries that you'll see had technology issues early on. That's something that will turn people off very quickly if the technology doesn't work. But even though it's text messaging, it's not as simple as you might think. And there are issues around how you set up the engine that runs all of this, who owns it, who's involved in terms of telcos or mobile network operators, who's running it, is it government, is it a third party? There's lots of issues around setting that technology up which are critical. And the other thing is that really making sure you have all the right support. So a lot of the issues with some of those countries in the beginning was that they thought that they had the right support, and then someone at the top changed along the way, and it suddenly was less of a priority. And without that really high level support, it's very difficult to launch a national program, as I'm sure you're aware. So those were just some early lessons from cessation, but now I'm just going to tell you quickly about two of our recent projects in using text messaging again. So we find that text messaging is just the most ubiquitous technology. So everybody can receive a text message program for free, just about everywhere, because it doesn't generally cost anyone to receive text messages. And so even for really low income people in our country who have a really old phone, who have no credit on their phone, they can still receive a text message program. And predominantly, as you'll see, these are the kinds of populations that we are targeting. We're really targeting those most in need. We're not targeting people who can download a smartphone app, usually, and who have a data plan and a nice new smartphone. We are targeting people at the lower end of the socioeconomic divide. So this is a program that was actually set up as a service, not as a research program to start with. So we were actually funded by the Health Service to develop this program. It's text messaging health information for pregnant women and their families. Do you guys know Text for Baby here in America? Some people do. So I, in 2010-11, I was in the States and I did an evaluation of that program. So it kind of comes a little bit from there. I went back home and said, we should do something like that here. So we did this program. The way it was funded, it was part of this consortium, which is basically a whole lot of community organisations that were dealing with Māori, which is the indigenous population of New Zealand, Pacific immigrants who are from a number of different Pacific nations, Asian new migrants and South Asian new migrants. So we have reasonably large numbers of these in Auckland. Auckland's a very multicultural city. And so the way we were funded was to develop this program for those kind of families, not for anyone else, but for new migrants and our indigenous population. And these groups along the bottom, they're the community organisations who are working with those families. So it was in collaboration with them. And the main context had to be about childhood obesity, again, because that's the way it was getting funded. So unfortunately, we are third behind you and Australia in terms of obesity rates, which is very unfortunate. And our childhood obesity is, it has been rising. It's actually kind of plateaued off now. We're hoping it's not going to rise any further. But particularly Māori, our indigenous population and Pacific children have really high rates of childhood obesity. So this was one of the things that we were particularly trying to address with this program. But I wanted to tell you a little bit about the development process because it was very long and involved because we were doing it for all these different cultural groups, not for Pākehā or New Zealand European, but for these other groups. So we were given the direction of an overarching, what we call a kaitiaki group, which is a guardianship overarching group. We ran focus groups in the beginning, which I'll tell you a little bit more about. We took the key messages from all of these huge booklets that are written about guidelines for pregnancy, nutrition, eating in pregnancy, and guidelines for activity in pregnancy. They're all about this thick. Rosie, who's not here with us, had to wade all the way through them and turn them into 160-character text messages. Not an easy thing to do, but luckily it wasn't me that had to do it. But so she was able to do that. We adapted it for text messaging, but then obviously it had to go through all of these other groups. So we took what we learned from our focus groups with young mums and pregnant women from these cultural groups. We applied that. We made sure that the key messages we were given were consistent with external opinions. So we had obstetricians, pediatricians, etc. Then we had to culturally adapt them for these different groups. So we worked with those organisations you saw in the beginning who are on the ground working with these families to culturally adapt every single message so that it would be relevant to the daily lives of these families that they were working with. Then we had to get that externally reviewed to make sure that was okay and was still relevant. Then we had to get them translated. Then we had to get them back translated to make sure they still said what we thought they said. And then we pre-tested them back with our focus groups to say, does this make sense to you? So it's a very long and resource-intensive process. And we learned a lot of really interesting things that we wouldn't otherwise have known by doing this. But things around pregnancy and nutrition in particular are very highly influenced by culture, very highly influenced. So we had to make sure that we got it right. Otherwise, they would have switched off really quickly. We've learned some interesting things about which groups wanted it translated and which actually wanted it in English, which was really interesting too. So for Pacific, for example, we have a number of different Pacific countries represented, and Pacific languages are just notoriously long. They're really wordy. All their words are really long, so they don't text in their Pacific languages, they text in English. So they wanted it in English, but we put all of the greetings and keywords around food and things like that in their languages. And even the new migrants often had quite good links to this kind of information from their home country, but they didn't want that. They actually wanted New Zealand specific information, which was why they were joining up. So some good things we learned there. And as we said, we went through this core message, cultural adaptation, then we got them reviewed by other people to ensure they were appropriate and relevant, and then we got them translated as well. So there's some examples there. So what we ended up with, this is some examples there of the messages that we ended up with. The program is very much about providing information, but also providing support and linking people back to those community organisations. So not answering questions. This is a one-way program, but saying, if you need more information about this, this is where you go. So we linked them to community organisations. The individual messages are tailored according to culture, ethnicity, language, but also when the baby's due. So they got relevant messages to the stage of pregnancy or relevant messages to the stage of that baby. So we started with their due date and then we moved to the baby's birth date. So it's chronologically relevant as well. And it's also available for the mother as the key person, or actually anyone else in that family. So anyone can sign up. They just say whether they are the expecting mother or they are someone else who's supporting a baby. And then they're individually personalised, as you can see in those examples, with their name and then their baby's name too. So what we ended up with is 16 different versions of one text message program. And by answering just 4 simple questions at the start as they go through it, they get channeled into one of those 4 different programs. So it's culturally adapted first, then it's got the right language, which may be translated or maybe not. And then it's either the mother or someone else in the family. And then down the bottom here, so if for the Pacific, for example, when it's in English, there's 8 different types of greetings and other ways it's tailored for that ethnicity, and the same with the South Asians over here. So as I said, it's a service, and over 4,500 people have been through TaxMatch so far. We get incredibly good feedback from people who go through it. So at regular intervals, we ask them how it's going and whether they like it, and whether anything they'd like us to change. And we get this kind of fantastic feedback. We did do a small evaluation. It hasn't really been fully evaluated in a proper kind of way, but we were able to do interviews. So we did a random subsample from people at all different points in the program, even those who had opted out. And got the right culturally appropriate people to do phone interviews with them to find out what they thought. So as you can see, is that one there? Yeah. So most of them found it to be relevant and culturally appropriate. So one of the issues is we don't know how much all that effort we went to in the beginning, how worth it is it, because it's a huge resource intensive process. But basically we found that most people thought that we'd done a reasonably good job of making the messages appropriate and relevant for them in their daily life. And a lot of them said that it had a positive impact in terms of their families' eating habits, their food shopping habits, their exercising and so forth, and also just feeling more supported, which is one of the things that we were really aiming to do. So we are really happy with that. We're still providing the program, and this is some more of the feedback that we get. So I just want to move on now to a different program, which was developed as a research program, not as a service, this one, which is a text message support program for people with poorly controlled diabetes. So diabetes, again, is a huge problem in New Zealand, and it's increasing rapidly. And as you see, with our increasing obesity rates, it's only likely to get worse. So what we wanted to do, well, we talked to a whole lot of people with diabetes and a whole lot of clinicians in the beginning and said, what could we do that could help? And what they told us was actually they wanted to feel more supported in between their clinic visits. So they felt that their provider was doing a pretty good job at managing their diabetes, but they're only seeing them once every 3 months if they were, at the most. And so what they really wanted was to feel that they were being more supported in between those clinic visits when they're making decisions every day around their diabetes. So that's what we set out to do. And using technology was particularly around accessing people who live a long way from their provider and who feel that they're not supported in other ways because their provider might not be culturally appropriate. So this is what we developed, a program for people with poorly controlled diabetes. It's, again, personally tailored, text message based. It does have a website component. But one of the things we really wanted to do was give people a sense of control over their program, because most of these people are not feeling in control of their diabetes, and a sense of control is really important. So it has a whole lot of modules, and they get to choose at the beginning which modules they receive. So there's a core program, just a few messages a week, or they add on these modules if they want. And the more they add on, the more messages they get. So they control the frequency of messaging. You can see what they are there. We also have a program for Māori, and a program for Pacific, and a program for non-Māori, non-Pacific. And if they want, they could ask for blood glucose monitoring reminders. And if they got these, they get to choose how often they got them. And if they got them, they could choose to respond with the actual glucose level, and then we would graph it for them. So that's the website that they could go to a website to see the graph of their own glucose results. It was for the purposes of self-monitoring and review. It's not for their clinician. They're welcome to show it to their clinician, but for behaviour change, it's for self-monitoring, self-review. And a lot of people did that as well, surprisingly. You've got some examples of the messages there. It's very much, again, about support and motivation. It's not a clinical program. It's not telling them what insulin dose to use. It's trying to support them and to motivate them to take better control of their diabetes. So this is just a framework that we have published that we used to help us with the steps. So particularly for this program, we did all of those steps. We had the target population involved the whole way in the design of the intervention. We have a focus on how will it be implemented at the end if it's successful. So we deliver it in the study in the way that we think it will be delivered if it's successful at the end, and with the behaviour change theoretical basis. And we do all those steps. So we start with talking with the target group. We do formative research, we do development and pre-testing, then we do a pilot study, and then we do a large randomised control trial as well. So we did a national randomised control trial of this program. People from all around New Zealand who are poorly controlled, so they had to have a high HbA1c to start with. And they received the program either for 3 months, 6 months, or 9 months, completely up to them whether they kept going for a full 9 months or they could stop at 3 months or 6 months. And we found about half of them stopped at 3 months, half of them kept going for the whole time. Again, we got really good feedback, but also we got great results. So we're very pleased with that. So this paper was published in the BMJ. It found that we significantly reduced HbA1c, which is the long-term measure of diabetes control in the intervention group, by we use different measurement units than you have here in the US. I can't remember in the US measurement units, but for us it was reduced by 11 millimole per mole, which is fairly similar to kind of drug trials, really. And it was statistically a greater drop in HbA1c, statistically significant compared with the control group, who did also improve a little bit, but the difference was still greater for the intervention group. And as I said, we got amazing feedback from people who thought that this was a great support for them, and that they wanted to be able to keep going, or they wanted to be able to get their friends and family onto it. But unfortunately, we haven't yet been able to get it implemented. So we kind of, according to our framework that I showed you, we think that we did a fairly good job at involving all the right people. So decision makers in the health service were involved, clinicians were involved of all sorts, Māori were involved, patients were involved. Everyone was involved in the development and the study. And they all said, yes, if it's implemented, we will help to get this funded. And if it's successful, we will help to get it funded and implemented. We got the right kind of results. Really good, high quality randomized control trial published in the BMJ, but it's still not implemented as yet. We're still working through a process with our Ministry of Health and our local health services to try and get them to fund it. So just last slide from me, thinking about lessons learned, that this funding around effectiveness and implementation needs to be considered right from the start. And so I've shown you two different models, one where we were funded to implement and one where we got a research grant to develop it and then tried to implement. Neither of them are particularly ideal. The first one we still haven't got a really good evaluation of. The second one we still haven't got it implemented. But you need to think about these things right from the start. Clinical champions are hugely important, and getting the right people in terms of that on board from the start is really important, and they can make a big difference in getting something implemented. Obviously we need evidence of effectiveness, but actually the user stories, the participant stories, are often the best thing to really explain how and why this works and to get people buying into the fact that this is a good thing to implement. And we have some fantastic user stories from our programs that we do use. But our philosophy is kind of start small, prove that it works, build some momentum, and then try and expand out from that way. That worked, and with some of our work, like with our smoking cessation, that's worked really well. Hasn't quite worked yet with diabetes, but we're hoping that we're still on that trajectory and that we will get there. So thank you. I'll hand back to Jude.
Are there any questions at this point before we hear a little bit?
And can you hear us clearly?
Great. Okay. So what I'm going to do now is just talk a little bit about a program that we adapted, an M cessation program that was developed. Robin mentioned that at the start of the presentation. It was developed and designed in New Zealand for a New Zealand population to help support that process of quitting. So some time ago, possibly even 5 years ago now, I think, or 4 years ago, Robin made a trip, was invited to the US, to Washington, to discuss potential collaboration with the US broadly, New Zealand, and to see where the two countries could come together and support some of the major challenges facing the Pacific region. I'm not sure if you're aware, but it's probably pretty intuitive now in a way that the Pacific Islands region has a major burden of non-communicable disease. In fact, the WIPO region, 70% of all deaths are attributed to non-communicable diseases. So this was a good opportunity to say, how can New Zealand and the US come together and put in some support to try and reduce NCDs, broadly speaking, in the Pacific Islands region, but also draw upon some of the new emerging sort of science and evidence around using mobile technology. So this sort of launched a 4-year program overall. I think it was originally 2 to 3, but it's still going on in some respects, to try and adapt an existing program that we found worked really well in New Zealand. And the logic being, well, it works well at home, we have a large Pacific population, surely we can adapt it. We don't need to start afresh. Now, the Pacific country we work with, there are 14 Pacific Island countries and territories. And as you can see, vastly spread across the region. And within each of those major countries and territories are hundreds and hundreds of other islands. So it's an absolutely fascinating and diverse region to work in. I've previously been working with colleagues in Samoa, doing something quite different. But I was very aware that they had a major tobacco problem. Like many countries in the Pacific, 14 countries all signed up to the Framework Convention on Tobacco Control. They had, at a government level of enthusiasm to support their population to quit. But again, like most or many low-resource countries, very little regulation, very little tobacco control, cessation support, and a very active tobacco industry in the country, even for such a small jurisdiction. So we talked with the Ministry of Health and got the sense from them that they were enthusiastic to work with us to try and see if we can adapt this tool and see if it could work. And we got funding to do this. So again, just a little bit more about the context, and I think this matters so much. We knew right from the beginning we weren't working with the New Zealand population. Even though we are only 4.5 million in New Zealand, this was a drastically even smaller population, about 190,000 people across 2 islands. We also knew that of all the challenges facing the region, and particularly facing Samoa, we knew that tobacco was up there at about 30–35% prevalence rate. But it wasn't like the most pressing problem the country was dealing with. So but we got a sense that this was still a priority, and the government, our government in New Zealand and the government in Samoa have a bilateral agreement to work on tobacco control. So that's good backing. We have a good sense that there was some high-level support. We also knew, and it was important to identify whether the region and country in particular was well-resourced in terms of telecommunications infrastructure. And yes, absolutely, they had 2 telco providers. Most people have a subscription and have a phone. So that was really important. You needed to know that information. There's no purpose or no potential to unroll, develop an end cessation program in the country. Mobile was really not very popular and widely used. So that was certainly important to get a sense of. And we know that the region is becoming increasingly connected. So if it's good now, it's going to get a whole lot better. So thinking ahead about what the future might look like in country was really important. Some of the detail around from the GSMA or International Telecommunications Union are very important. They give us a sense of subscription rates across the region, but they don't burrow down much deeper and tell us who actually uses phones, whether more men versus women, and so forth. So that was something we had to sort of figure out as well as we went along. So what we decided to do, or what we set out to do, was to try and adapt this tool, start this support program, text-based support program for quitting smoking, and adapt it for Samoa. And we had 2 key outcomes. So when we were funded, we wanted to adapt this tool. We wanted to see what the process was for adaptation. So not just adapt it and then put it out there and see whether it helps people quit, but actually, what does it take? What is the process when you take a tool that's been very specifically developed for a high income setting, where there is a lot of tobacco control infrastructure, mass media campaigns and quit lines and fully subsidized NRT, and then adapt it for a setting where there was nothing. There was no NRT. You could buy a gum at the pharmacist for about $1 each, stick of gum, so really expensive. There's very little mass media campaigns. There was one running at the time, but kind of in a very sort of fear-inducing type of campaign. So essentially very different context. So we want to understand the process. We want to understand actually that it help people to quit, importantly. So the process of understanding of what it took to adapt was something we were interested in as researchers. Our funders, of course, were most interested in does this make a difference. We also included in our funding model a cost-effectiveness evaluation. And that was super important from our perspective. Even though it wasn't a requirement from our funder, we wanted to come away and feel confident that we knew that this intervention cost X amount of money. And so you could compare it with what else you could perhaps buy for that amount of resource as a comparison. So that was important, and that's just about it has been undertaken and completed. So that was what we set out to do. So this is not a very good slide, doesn't show up terribly well, but what we wanted to do was, this is what we provided to our funder. So a really comprehensive sort of work plan. And this was a really important exercise because what it did was strictly freaking out and go, actually, what realistically can we achieve? Well, we're taking a tool that was developed in New Zealand, works really well, to another country. So the key outputs, and clearly we wanted a fully costed model. How do we scale up this tool for other countries in the Pacific? We're all kind of looking on saying, does this work? We use it here. We want to set up a governance network. We want to ensure that there was good infrastructure, personnel support that would start right at the beginning of the program and continue through when we'd finished doing the pilot. We wanted a program. We wanted to say, here's a program, an initiation program that you can have and deliver, and perhaps can adapt for other settings. And we also added in a mass media campaign. That was something we weren't originally requested to do. But what we wanted to do that for was to build up, alongside this intervention where people receive text messages, is kind of build, I guess, a broader population awareness of quitting, what it meant for someone to quit. And what that would do, ideally, is provide more support around the social environment. So, but essentially, so this was, in terms of short-term outcomes, we provided a comprehensive understanding of the process. We needed to strengthen capacity for leadership and MCSation. Again, nothing happening before then. And then we wanted to increase public awareness. So this is the project overview and kind of what we had to go through in order to take this tool from New Zealand and adapt it. We did some initial engagement. We had to get ethics approval because we're going to be collecting this data and reporting on it potentially. We did an exploratory study because the first thing we needed to do before solving a problem, we needed to understand it. How do people use tobacco in Samoa? We couldn't assume it was the same in New Zealand. The behaviours and kind of rituals around tobacco use, not that tobacco is used in a ritualistic way necessarily in Samoa, but what was the kind of times that they preferred to smoke and what sort of meaning it did have in their lives. So that was really important. And we needed to test out those messages. So the messages that were developed for New Zealand were then tested with a group of smokers and ex-smokers in Samoa. Did they like them? Did they like the language? How could we change them? So there was a long process of adaptation around both the types of messaging, the tone, the formality versus informal language, the use and translation of medical terms or specific terms. So a lot of that, as Robin mentioned, was a lot of backwards and forwards. And as non-Pacific researchers, from an outside institution, we stepped right back from that. A lot of that work was done with our colleagues, obviously in Samoa and with the Ministry of Health and other key kind of NGOs like the Samoa Cancer Society, until they essentially came up with a set of about 190 messages, all 160 characters. Again, a lot of work to shorten them because Samoan language is very long. So that was a really backwards and forwards iterative process. And we were super, I think, conscientious of doing it right. And we didn't want to stop testing and making sure it was right until we got that confirmation from a person who was identified perhaps somewhat later down the track. And the Ministry of Health said, yes, this is the right type of message. And then they were given out and people really liked them. They thought they were respectful, they were motivating, they referred to things that mattered to them. So in Western societies in New Zealand, we drew a lot upon individual motivators to change. You have more money to go shopping, or, you know, things. Whereas in Samoa, it was about spending time with family. That was really important. So making sure we could have those connections. So we worked on that for some time, and we do question in hindsight the efforts we went to. Did we just go and spend way too much time getting this right? Is there such thing as an absolutely right message? So those are things we still question, you know, is actually just the reminder that you have been signed up to quit, and that message sort of comes to your phone. If the people really, really look at those messages and take on board and read them very carefully, or is it something else going on? We still don't really have the answer to that. And then, like in the project timeline, these things, I guess, in doing them the way that we were very careful because we were coming from an outside organisation, trying to work with in-country partners, that we weren't just mowing in there with our ideas and not stepping back and taking that time to do it very carefully and consciously. And so the process was, very similar to what Robin's identified. We start with some focus groups. We tested what they thought about or questioned what they knew about in terms of quitting or what they prefer to do, adapted that sort of practice sort of information into the text, so getting the language right. We updated and retested those messages. Then we recruited 100 smokers. And that was relatively straightforward. Here we are, you know, recruitment, as you know, is incredibly time consuming and trying to get that perfect, you know, that number we want looking for. But in Samoa, it was relatively easy because of the social networking organized, the way the society is organized. Went out and recruited people relatively swiftly. We also launched this mass media campaign at the same time. So out on TV and radio, they were hearing about quitting smoking and the importance of it. And that was done very carefully. It was based on the Every Cigarette is Doing You Damage campaign that has been, I think, translated and adapted for 100 different countries. It's national, the Lung Foundation. So it's really a great, very thoroughly evaluated campaign, and it was refilmed in Samoa, fully linguistically adapted. Again, we stood back from that and we got local filmmaker in to help do that process. We followed up smokers for 3 months, and then we looked at the cost. If we scaled this up beyond 100 smokers, what would it cost the Ministry of Health Samoa? And we worked out it cost 20 tala, which is 10 New Zealand dollars, which is, I can't even think of what US at the moment, but yeah. So just going back just a little bit here, so this, what the focus groups found that yes, people have phones, they share them though, they don't typically own at the time, you know, not, a slight majority owned a smartphone, but the majority don't, or certainly half of them don't. We'd expect that to change. And they use SMS. As Robin said, people go, why are you still using SMS? And then there's so many more exciting things in terms of technology. But in the context of Samoa, and I suspect across other Pacific settings, text messaging is still really important. So those who signed up to the program had the series of text messages. It's been designed along around the theory of behaviour change, so they're all very sort of scripted to be responding to those different phases of quitting, from the stated quit date to relapse prevention. And that was the program that participants received. So just finally, what we found. So the program, number one, was successful. It did help people to quit. We got a similar rate of quit as we did with the New Zealand trial. And it's what we found elsewhere. So that was really important. Yes, this is also feasible. We can roll this out potentially. One thing we had to be really aware of, with 2 telcos in one country, we went with people could sign up to Digicel or Blue Sky, and we had an issue with those who were on Digicel not receiving the messages in the same way. So again, figuring out, you know, you're kind of juggling these balls. You're trying to work with the government and go, this is potentially really good, and you involve them and include them very much along that process. But you're also keeping an eye on the telcos and how they're operating. And they really want to share their messaging and their platforms with their competitor. So what we found in terms of so we had to, again, I'm jumping back a bit here, but the cultural adaptation and translation was really important. We knew that text messages had to be personalized, that we had to adapt to the timing of the messages. People did not want to receive a text message when they were in church, but they certainly needed to get a text message after they'd had a meal, because in Samoa, the perception was that smoking is a digestive. It helps you digest your food. So you eat enormous food, it's very important. Meals are reasonably substantial. There's nothing like a cigarette after a meal. So that was a perfect time. So we had to be very careful around those timing of sending messages. And again, as I said, referencing local things, but not so specific that this program would have to be updated every year as this particular cultural event had moved on, or that beach was no longer the place to go to. So really generic, but localized. One of the things that we were questioning, and this is something I'd like to discuss with you if we had time, is again this whole concept of SMS and individualized messaging in a country like Samoa, where the culture is very much more organised along collectivist lines. New Zealand, predominantly, we look after our own health. We're interested in others' health, our own children, but our networks are not structured in that way. So when we think about using text messaging, while it's feasible and you can adapt those messages, yes, you can get them out to the population if you've got the right people in place. Is an individual message going to an individual person really the right way to do this? In a society that's all about social connections. So that's something we're trying to explore in our network that we're hoping to develop, looking at social networking sites for pushing messages out. We also look at the whole concept of behaviour change as the foundation of this whole process. That behaviour change is this iterative process where you kind of go through these stages, almost in quite a linear fashion. Does this really work for everyone? We know that there's some common human behavioural kind of traits and so forth and processes, but the concept of the linear process for behaviour change in the context of Samoa, maybe we need to think a little bit more about that. And not Robin and I, but our Samoan colleagues. How does behaviour change work in a collectivist social environment? And maybe we're not talking about individual behaviour change. Maybe behaviour change is a process that comes out of social change. So those sorts of things are really, I think, interesting to look at. And the final question or thoughts I want to make is that, yes, adaptation was feasible. We can certainly take tools that have been done and developed elsewhere, wrangle them into shape so they can fit different contexts, both at the individual user level, language, timing. The tricky bit is what Robin mentioned about the SMS4BG. Can we adapt them so they fit into a health system, particularly health systems that are kind of fragile? That when they have a lot of donor activity, and particularly countries like Samoa, they are inundated with countries offering all sorts of useful, helpful things. How do they manage that? How do you, when you intervene and put a cessation program into a system, how do you measure its kind of the ripple effects of that and organize the systems that need to support it? So those are the things that I think are really important to consider that are not quite so straightforward. We want to question how far to adapt these messages. I mean, we were excruciatingly cautious in our process. And the time it took, and time is resource. So this cost a lot to get those messages translated and perfectly refined. We question whether that is that important. We don't know, maybe it is, but I'd like to know and be nice to compare actually how far we need to go with that process. We want to know that the impact is sustainable over time, and I think that's really important, not just, as I said, at the individual level of behaviour change, but you can sustain that program. And it can become, we talk about ownership, but really meaningfully ownership by that country so they can then make those adaptations and bring in and apply it for other health issues. Is that potentially doable and then sustainable? We also know that adaptation is really good, so tools that have been developed in neighbouring countries that are very obliged and enthusiastic in supporting neighbouring Pacific countries, but are they any better than what can be designed in country? And maybe developing that not just capacity, but also capability to develop own programs and not rely on kind of programs that have come from elsewhere, despite the potential or perceived efficiencies of that process. We also question this idea of the individual model. The behaviour change, as I mentioned before, is that really the only way to go just because it's been established and well written about in health psychology theory? Maybe there are other ways of doing things. And as I said, can we look at, I'm talking about text initiatives, but I'm more thinking, our group is thinking more around other social networks, really looking at how they organise and mobilise action in a more organic way rather than a didactic text message from organisation X to individual Y. So, and then we want to be careful. I think one of the things we have to be very conscious of with text-based or any technology-driven intervention is around equity. Unconsciously or inadvertently, are we exacerbating social inequities? And taking the assumption that everyone has a phone and they all like to receive messages, I think we'll be very careful about that. So I think we need to really be much more inquisitive and much more careful about making sure that we understand what the end user, so to speak, is looking for. What is the problem before we automatically apply a technology-based solution to it? And then if it is a tech solution, because of all its potential efficiencies, reach, actually that is adapted really well for that particular group, because I think that's where we can potentially amount enthusiasm to roll forth with this technology, is perhaps leave people and populations behind. And I think that's, and measuring impacts, I think that's the final thing we'll say. This is really the tricky, even though there are toolkits and frameworks and checklists abound now that have been published that are really useful for what to do to make sure you're doing what you set out to do. They're not that straightforward. They're very complex models and programs, and I question the practicality of them. So coming up with ways of measuring impact that is really feasible, not just from the outside donor perspective, coming and seeing whether your investment has paid off, but actually for in-country people who are rolling these out. Finding ways of being both robust but pragmatic in terms of identifying impact is important from our perspective. So I think that's all we've got to talk about. So really happy to take questions if you have any. Thank you.
I find the and I'm wondering if you had any measures to understand the Samoan opinion of kind of the cross-cultural piece of it. If they,
from their perspective?
Yeah.
I think that's a really good question. And I think one of the things we did do a process evaluation. So right at the very beginning, and this wasn't part of the, I think we carved off a little bit of the funding because funders don't like wasting resources to see whether it actually works, except for the output. Did people quit? So what we did was we had an external organisation go through and interview people throughout the process. They collected every meeting notes, they did a full document analysis of all of the meetings and everything we did that was produced from the concept to the finish. What you're asking about is a really interesting question, is what did the users actually think about this? Now, feedback anecdotally and informally from the follow-up evaluation was very positive. And I had some slides I could have shown you. So they really liked their support. They felt that it was appropriate, it was respectful. It's certainly in the context of nothing else that providing the provision of messaging support was very much appreciated. So we certainly had very similar to what Robin presented. And we asked the question, is this right for Samoa? Is this a Samoan or Fa'a Samoa, as they call it, way of operating? And we certainly got that enthusiasm. Now, my sense is that in comparison to something that's more social network, I do think that that's where it would fall slightly short in that regard. I do think that they did question when we were talking with people, oh, we should do this as a group. We should all get messages. You know, a whole workplace would do this better. So they talk about one of the difficulties for quitting was that I'm the only one who's going to quit. I'm going to be shut out of the social group as when everyone goes out for a cigarette at morning tea or whatever. So I think that's a really good question. Thank you.
Dr. McCool, thank you so much, so helpful. Actually, I have a process question about money, and I apologize if you're late. You talked about funders. Who in New Zealand, I know the university lost very large, you applied for funds there. Does the government support this kind of work that you're doing? And other folks that they...
Yeah, that's cool. So, using those examples that we talked about today, so the effective-ness was funded as a service by our household. So they decided it was really good funded as well. The diabetes one was funded from a number of places, including the same health board, but also our New Zealand Health Research Council, which is like it's our only really big health research funding, and the success rates are about to get funding. And the Ministry of Health actually weighed in with the funding. So we got a proposal funding to build an part in New Zealand, and the Ministry actually contacted us and said, we want to do this. So I other places as well, obviously outside of Auckland, but we work in rural and remote areas. So it's becoming kind of a national part for the cities over time. So it's often pulling bits and pieces together. I mean, same with Samoa, we initially got some health research council funding that came out of the meeting that I went to, but then we kept that up. We've got that up really with our aid.
Yeah, so the Ministry of Foreign Affairs and Trade, the irony of that is it was very obvious when you're thinking about chronic diseases. Anyway, they were very keen to support this. They weren't keen though when we went back and said, look, this has proven to be feasible, people want it, it's shown effect. Can we just have a little bit more funding so we can appoint somebody who we've been working with along the way to train them to do this, to continue? So that's when they go straight to domestic resourcing, has to come in. So I think that's one of the really, and so the question is really right at the very beginning when I mentioned how important the cost effectiveness evaluation was, because we were thinking, how are we going to sell this? How are we going to not sell this to our funder, so much as how are we going to provide the evidence for whether or not this should be continued, and that would potentially then support whether it came partially New Zealand aid funding, so to speak, and some on domestic resourcing. So these are really tricky process.
We were trying to set out for this not to be seen as a New Zealand program or New Zealand program, but it can be a run-on New Health and program. We were developing it for them and with them, and we hoped that they would take ownership of it during the process, and at the end of it, they would see their program, and they saw a successful, they would pick it up and run with it. And that kind of didn't.
But then it's coming, but timing is really important. So a few weeks ago, just before I left to come to the US, I had a meeting with the Ministry of Foreign Affairs, and they said, look, they want to know about the Samoa cessation program. They said, oh, the timing, great. So they've just had a major structural change or realignment of the health system. This is the time to bring it in now. And so it's now, and again, it's finding that I was always aware that where you fit this, where would the end cessation fit in the health system structure? Does it come under the health delivery side? Does it come under health policy and planning? Does it come under, so kind of all the way trying to figure out, and as an outsider, it's a bewildering process. As an insider, I'm sure it's equally bewildering, because one thing that was really, we noticed in Samoa, which was, and this is very typical across very small jurisdictions, I guess, is that cessation was a priority when you were there. Everyone was very enthusiastic, wanted to see it up and running. In fact, why isn't it running now? We want it up and going. The WHA was involved. Then things happen, a chikungunya outbreak, bang, nothing happens for some time while they get on top of that problem, which is absolutely immediate. And not only that, is they're very focused on various events for the week. So they're very keen on health promotion. So it might be breastfeeding week. So the entire Ministry of Health drops everything and starts focusing on the activities across the two islands around promoting this. So it's just trying to kind of keep this there, but without kind of obnoxiously pushing it, because again, it's not their agenda. So going and making sure what you're doing is absolutely aligned with that health sector plan. And not only that, it's aligned with an agreement they've also got between, say, Samoa and American Samoa had a bilateral agreement, a quasi-competitive process of who's going to be first to get NCD interventions up and running. They're kind of slipping on, well, this would be, you'd be the first to get this going. So mobilizing those regional and between country agreements was really important. So again, back to funding, it's tricky, although we've just received some funding from WHO to adapt this program for the Cook Islands. And that's purely implementation. They just said, can we get this up and running? The Cook Islands, again, very keen, and it's come from the Cook Islands. We haven't gone out there touting for business saying this is what you need. They said, we'd like this. This helps us to achieve our goals. So we'll have to have that up and run and delivered and evaluated by December this year. But that's good. I mean, that's all doable. We know we can do this. We know we don't need an enormous amount of resource to adapt it, because we can probably make some quicker steps. So, yeah.
You mentioned health delivery. from a primary care provider. Can I get my patients? Either one.
So the diabetes one, we did have a brief conversation as well as the diabetes clinic, so that's how I got the word out from the visit. So we get a lot of primary care who want to be able to access these kind of services, but they want it to be really, really difficult. So they want like kind of push button on their tax management system. These are real issues. So we are not able to make that happen. There's no leverage. We don't see it as a priority. Nobody wants to fund it for the work to do it. So, you know, so that we're a bit of an impasse there. We have talked to a whole organisations and we also do someone, but the only one that is the push button and enroll someone like that. And that's the shift that we're doing.
I think answering your question in the context of actually for the Cook Islands, in our early discussion with them, they see the benefit of cessation is that their primary care or primary health team is so small, and those who are devoted to trying to helping people quit is even smaller. So what they're seeing, this is awesome. So we can actually do some face-to-face support work with people, but for other people, they can be enrolled into this program. And it's certainly in terms of task shifting and, you know, being economizing on human resource capital, they see some real benefits from that. Not say that you pull out completely, because some people both want face-to-face support as well as tech support, but they see that probably very much running through that you know, I think primary care. Yeah. Sorry. Okay, anything else? Well, thank you so much for organising this. I really appreciate it.